Hello again, wonderful staff of the Northwest Kidney Center, with a special nod to those who work at the Kent facility, which as you all know is the apex of this wonderful organization and where you find the best clinical dialysis care in the Northern Hemisphere. Welcome to the Halloween edition of our monthly in-service. Today we'll discuss ultrafiltration in hemodialysis patients, which is not really a scary topic unless you do it wrong, in which case it can cause some very scary clinical complications. There are four objectives of today's talk. First, we'll define ultrafiltration. We'll review ultrafiltration profiles of the Braun hemodialysis machine. We'll discuss associations between high ultrafiltration rates and clinical outcomes. And finally, discuss strategies to limit ultrafiltration. Let's begin by defining ultrafiltration. Ultrafiltration is the process by which fluid and some solutes are removed from the patient through the process of filtration under pressure. It occurs when fluid passes through a semipermeable membrane, so a membrane that allows some substances to pass through but not others, due to a driving pressure. So in this picture, water, ions, amino acids, and small sugars are able to pass through the membrane, but larger proteins and complex sugars cannot pass through. Ultrafiltration is one of the functions of the kidney that dialysis treatment replaces. The kidneys, of course, get rid of fluid and solute in the form of urine. Dialysis patients typically lose the ability to urinate regularly, and therefore fluid retention is a very common problem for them. In order to understand fluid removal during dialysis, it's important to understand the distribution of fluid in the body. So about 60% of the adult body weight is composed of fluid. So we are mostly water. The percentage is higher at birth and declines with age. An average 60 kilogram person contains about 40 liters of water. And this is distributed among 3 different spaces or compartments inside of the body. 40% of the fluid, so about 25 liters, is located inside of the cells in the intracellular space. And most of the fluid in our bodies is therefore located within our cells. Now, 20% of the fluid, about 12%, or 12 liters, is located outside of the cells, but still in the tissue. We call that the interstitial space. And only about 5% of the fluid, so about 3 liters, is located inside of the blood vessels, and this is the plasma volume. Note that the actual plasma volume is relatively low, on the order of 3, maybe 4 liters in most patients. And yet in a dialysis session, sometimes we remove, 3 to 4 liters. How is this possible? Well, it can only be made possible by the movement of fluid from the intracellular and interstitial spaces into the intravascular space to replace what is removed with dialysis. So fluid movement throughout the body's 3 compartments is dynamic, particularly during the dialysis procedure. So how does ultrafiltration work? Well, pressure is applied to the dialysis membrane on the blood side, and that forces water and solute across the membrane. Now, ultrafiltration is an incredibly important tool that we use to treat our dialysis patients. Why is this? Well, volume overload is really common in dialysis patients because they don't make a lot of urine, and that's associated with the development of hypertension and cardiac dysfunction. Now, cardiovascular disease is the leading cause of mortality, accounting for more than 50% of deaths with known causes. And cardiovascular disease itself is 9-fold higher in these patients compared with age and sex match controls in the general population. Now, several factors may be responsible for the increased cardiovascular mortality in dialysis patients, but sodium and volume overload are considered among the main mechanisms in this association. So in dialysis patients, kidneys are unable to maintain proper sodium in water, homeostasis, and because of the intermittent nature of thrice weekly dialysis, people oftentimes gain large amounts of fluid, or interdialytic weight gains are high, and that leaves people chronically volume overloaded. So sodium volume accumulation is inevitably large, particularly during the 3-day interdialytic interval, and that leads to high blood pressure, and high blood pressure in turn leads to increased cardiovascular disease. So ultrafiltration is an incredibly important tool for controlling blood pressure in dialysis patients. Okay, let's now talk about different ways ultrafiltration can be performed during dialysis. This involves something called ultrafiltration profiling. This is essentially the practice of varying ultrafiltration rates to maximize fluid removal during a treatment in such a way that it minimizes intradialytic hypotension as well as symptoms such as cramping. And there are many different pre-programmed profiles in our Bebron dialysis machines, a few of which are clinically useful and the rest of which are more academically interesting but not often used. Okay, so profile 0, and I think also in the Bron machines, profile 10, represents constant ultrafiltration throughout the dialysis treatment. That is, it offers a constant steady pull of fluid throughout the therapy. So this is the most common ultrafiltration setting for hemodialysis patient, and it allows for the lowest ultrafiltration rate possible during the treatment, that is, without extending the treatment duration. The next profile that's clinically useful and with which most of you are probably familiar is profile 11. This is linear profiling with more ultrafiltration at the beginning and less at the end. And so this is used for patients who can tolerate more fluid removal at the beginning of the therapy with a gradual decrease to lower the amount at the end. And it's thought to be ideal for patients who are inclined to drop their blood pressure at the end of the treatment or who tend to cramp at the end of therapy. The next profile I'd like to mention is profile 13. I wouldn't say that we often use it or that it's clinically useful, but it is very similar to profile 11, so I thought I would mention on the same slide. Similar in the sense that more fluid is removed at the beginning and less at the end, but rather than a linear reduction in the ultrafiltration rate, it represents an exponential decrease over the course of the treatment. So the profile starts off by taking a really large amount of fluid during the first 10% of therapy and then rapidly drops down to a lower ultrafiltration rate. Again, similar to profile 11 and thought to be ideal for patients who can tolerate a large amount of fluid removal at the beginning, and particularly good for patients who tend to drop their blood pressure in the middle and the end of therapy or have frequent cramping. The last profile that is clinically useful, I think, is profile 16. On some machines, it's profile 17. And this is ultrafiltration alone without diffusion. So this is your standard SUF-run profile for patients with volume overload. And as you can see, it offers a constant steady pull of fluid throughout the treatment. And that's pretty much it for useful profiles. But for fun, we'll go through some of the others that are available. Okay, so let's look at profiles 1, 2, 3, and 5. So these 4 profiles are essentially the same variation on a theme. So they vary the ultrafiltration rate during the treatment depending on the particular circumstance. So profile 1, for example, represents a gradual increase in the ultrafiltration rate, maintained the higher rate in the middle of the treatment and then decreases the ultrafiltration rate at the end. And it's thought to be useful for patients who maybe drop their blood pressure at the start of dialysis and then tend to cramp towards the end of the treatment. Profile 5 is a similar idea. Basically, it starts with a low UF rate, increases slowly throughout the course of the run. Again, theoretically useful for patients who have a tendency to drop their blood pressure at the onset of dialysis. Profile 2 is theoretically used more in the acute setting when a patient is unstable and is maybe given osmotics such as blood or albumin at the onset of therapy. Essentially, it delays most of the ultrafiltration until the osmotic is on board. Of course, it's not recommended in the outpatient setting, particularly among patients who have a tendency to cut their treatments short. Then finally, profile 3, it's used for volume overloaded patients from whom you want to remove more fluid at the beginning of the treatment and whose blood pressure tends to drop towards the end of therapy. So the machine pulls the majority of fluid during the first 40% of the therapy when the patient has the most to give, and then the body adjusts to the lower fluid volume during the remainder of the therapy when diffusion and less ultrafiltration is taking place. Okay, profiles 7, 8, 9, 12, 14, and 15 are all similar in the sense that the ultrafiltration rate goes up and up and down during the treatment, a little bit like a yo-yo. Most of them end up with ultrafiltration rates that are lower at the end, which in theory is good for people who tend to cramp a lot at the end of their treatments or whose blood pressure falls towards the end of the run. The staggered ultrafiltration rates are thought to be useful for patients who have difficulty shifting fluids freely from the tissues and into the vascular space, particularly like diabetics, patients who have heart failure, elderly patients, and also for patients who have difficulty removing fluid at the beginning of therapy. The ultrafiltration rate is low at the start for patients whose blood pressure falls with dialysis initiation and low at the end for people who cramp with fluid removal, particularly towards the end of the run, or who have hypotension at the end of the run. Okay, profile 17 is an example of sequential ultrafiltration in which a lot of fluid is removed by itself, so just UF alone during the first part of therapy, followed by resumption of hemodialysis for the remaining 2/3 of the run, during which the ultrafiltration rate gradually decreases. And this is just one example of sequential ultrafiltration. There are actually several different sequential ultrafiltration profiles available on the Braun machine. Okay, let's now turn our attention to the important concept of the ultrafiltration rate. So the ultrafiltration rate is the volume of fluid removed per unit time that has been normalized to the patient's body weight. So it's important to normalize the rate of fluid removal to the body weight because bigger people have more fluid in their body, and therefore removing fluid from them represents a smaller change in total body volume than for a small patient. That is, removing 3 kilograms from, say, a 150 kilogram patient is not the same as removing 3 kilograms from a 40 kilogram person. The calculation's fairly straightforward. If, for example, we remove 2 liters of fluid over a 4-hour run, the speed of removal, so the ultrafiltration rate, would be 500 milliliters per hour. But if you divide that by the body weight of 70 kilograms, the UF rate normalized to body size becomes 7 milliliters per hour per kilogram of body weight. The goal is to keep this below 13 milliliters per kilogram per hour per kilogram of body weight. Okay, so there are basically 3 variables involved in the ultrafiltration rate. The ultrafiltration rate will be high if the ultrafiltration target is high. So if you take off 4 or 5 kilos, you're going to have a high ultrafiltration rate. Or if the treatment duration is short, so if you only dialyze someone 2.5 or 3 hours, you have to remove more fluid, in a shorter period of time. Or if the patient is very small, say a 40 kilogram person. So in order to keep the ultrafiltration rate low, it's important to minimize interdialytic fluid gain, so the fluid gain in between dialysis sessions, and to use longer treatment durations. So as we just discussed, a shorter dialysis duration increases the ultrafiltration rate. So again, if you have to take off, 4 kilograms in 3 hours rather than 4 hours, it needs to be done at a faster rate. And guess which country has a shortest dialysis average dialysis duration? That's right, it's the United States of America. So about 30% of the U.S. dialysis patients dialyze for less than 3 hours. Why is this a problem? Because the shorter the dialysis duration, the more fluid we have to remove per hour during dialysis, which means a high ultrafiltration rate. And high ultrafiltration rates have been associated with worse clinical outcomes. Which brings us to the next portion of our talk, a discussion of high ultrafiltration rates and clinical outcomes. So the basic principles are the following. Blood pressure in a dialysis patient depends largely on the amount of fluid inside of the blood vessels, so the intravascular space. Rapid fluid removal, or ultrafiltration, removes fluid from the intravascular space, which can promote intravascular volume depletion. This leads to a fall in blood pressure, and that can cause adverse cardiovascular events. Actually, several studies have shown a strong association between high ultrafiltration rates and adverse clinical outcomes. So Saran published a study in 2006 out of the University of Michigan in Ann Arbor, looking at 22,000 hemodialysis patients in 7 countries. This is data from the DOPS trial, of the Dialysis Outcome Practice Pattern Study, which is a multinational observational trial of dialysis in 7 countries, and evaluated the risk of death associated with dialysis duration and ultrafiltration rates. What was reported in the study is that reducing dialysis duration less than 240 minutes, so below 4 hours, increases mortality. Rapid ultrafiltration rate is associated with greater mortality, and every 30 minutes longer of dialysis was associated with a 7% lower reduction in mortality. And that's demonstrated in this graph here. So again, the longer you dialyze, the lower your mortality. Similar findings were reported by Movilli in the American Journal of Nephrology in 2013. This was a 5-year prospective observational multi-center study from Italy, which looked at 287 hemodialysis patients, 165 men, 122 women, on dialysis for at least 6 months, and the median dialysis duration was 48 months. And what they found was that in addition to age and diabetes and heart disease, the ultrafiltration rate was an independent predictor of survival. So specifically, an ultrafiltration rate of greater than 12.37 milliliters per hour per kilogram of body weight was associated with significantly worse mortality, as demonstrated on the survival curve. Similar results were reported by Flythe using data from the HEMO trial. This is a study from the Brigham Hospital in Boston. Basically, the HEMO study was a randomized clinical trial published in 2002 and involved almost 1,900 patients undergoing thrice weekly hemodialysis. And they used an interesting 2x2 factorial design in which patients were randomly assigned to either high or low dose dialysis and to either a high or a low flux dialyzer. And this was a sub-analysis or sub-study performed, which looked at ultrafiltration rate in clinical outcomes. What they found was that patients who had an ultrafiltration rate greater than 13 milliliters per hour per kilogram had significantly increased all-cause mortality. This is shown in this graph here, and the relationship was linear. The higher the rate of fluid removal, the greater the mortality. And the final study that I'll show you looking at ultrafiltration rate and clinical outcomes, published by Assman in December of 2016. This is a retrospective cohort study from the University of North Carolina that looked at 118,394 hemodialysis patients dialyzing in a large dialysis organization between 2008 and 2012. What they did was they looked at mean 30-day ultrafiltration rates, and they split you into 2 groups. Basically, either 13 mils per hour per kilogram of body weight or an ultrafiltration rate of 10 mils per hour per kilogram of body weight. And basically, they normalized them to body weight, body mass index, body surface area, and they followed the patients for a mean of 2.3 years. And they looked at all-cause mortality. It turns out that at baseline, 18.4% of the subjects had UF rates greater than 13 mils per hour per kilogram, and almost 50,000 patients had UF rates between 10 and or greater than 10 mils per hour and kilogram of body weight. And compared to UF rates of less than 13, rates greater than 13 mils per hour per kilogram were associated with 31% greater mortality, compared to UF rates of less than equal 10. UF rates greater than 10 were associated with a 22% greater increase in mortality. So, in conclusion, the author showed what the other studies have shown, that higher UF rate is clearly associated with greater mortality. So why is a high ultrafiltration rate associated with increased mortality? The leading hypothesis is that if you remove a lot of fluid very quickly during dialysis, it can lead to intravascular volume depletion, which causes intradialytic hypotension, so low blood pressure during the dialysis treatment. If you don't have enough pressure perfusing your organs, it can lead to what we call myocardial ischemia, where the heart doesn't get enough blood supply. Over time, this can cause a lot of scarring in the heart tissue, and scarring oftentimes promotes arrhythmias. This study supports the hypothesis that intradialytic hypotension can precipitate cardiac ischemia. It was a 12-month observational cohort study of 200 hemodialysis patients who underwent an ultrasound of the heart, or an echocardiogram, at the beginning of the study and again at 12 months. What did they find? Well, patients whose blood pressure remained stable during the dialysis sessions demonstrated no abnormal wall motion abnormalities on echocardiogram, so their hearts worked well. However, patients who had significant drops in blood pressure, say up to 30 points, demonstrated significant wall motion abnormalities during the dialysis treatment, suggestive of a concept called myocardial stunning. Essentially, the heart muscle does not work because it's not getting enough blood supply. And this was present in a whopping 64% of the patients, and was associated with the development of heart failure and increased mortality by the end of the study period. Now, all of these studies are very provocative, but there are limitations that we have to acknowledge. First, all of them rely on observational data. So observational data are useful for establishing associations, say between ultrafiltration rate and mortality, but not necessarily establishing causation. That's because there are potential confounders or alternative explanations. So, for example, poor adherence to fluid intake or low body weight. Or maybe, for example, the patients whose blood pressure dropped the most needed more fluid removal because they gained lots and lots of weight in between their dialysis treatments, and maybe the large fluid gains alternatively explain the high mortality. That said, since many observational studies have demonstrated a consistent association between high UF rates and mortality, it seems prudent to try to keep the UF rate as low as possible. So how do we do this? So here are options. We can decrease the amount of fluid that we remove per treatment. We can encourage patients, of course, to minimize how much fluid they gain in between treatments, or we can increase the treatment duration. Some people have even proposed making all dialysis treatments 4 hours. This would be very difficult to do. Flythe published a study in 2016 of 150,000 dialysis patients from a large dialysis organization, and basically calculated the additional treatment time that would be needed. So if we had to lengthen everyone's treatment to 4 hours or 5 hours or whatever it is to achieve a UF rate of less than 13 mils per hour per kilogram of body weight, it turned out that larger dialysis facilities would requiring an average 33 additional treatment hours per week, which is a staggering amount of extra dialysis. Now, in addition to turning dialysis schedules upside down And in addition to the huge burden of costs, there are other complicating factors. These include scheduling and transportation, staffing problems, and perhaps the hardest of all, patient acceptance. Once you're dialyzing 3 hours, it's very hard for you to be convinced to dialyze for longer. The other option is, of course, decreasing how much fluid we remove during a dialysis treatment. This is only possible if we can convince our patients to consume less fluid in between their dialysis treatments. That involves a dietary sodium restriction. We want to reduce the amount of sodium in the dialysate so that we don't actually give patients sodium throughout the treatment by the process of diffusion. And of course, we have to accurately assess people's volume status, make sure that we are removing enough fluid to keep them safe. Okay, let's summarize what we've learned today. First, volume management during dialysis is incredibly important. And ultrafiltration is a really important tool for making sure that we keep our patients breathing comfortably, their blood pressure is well controlled, and keeping their cardiovascular system healthy. A higher ultrafiltration rate is associated with intradialytic hypotension, poor organ perfusion, and stunning of the heart and other organs. Higher ultrafiltration rate is also associated with increased mortality and cardiovascular death. Limiting ultrafiltration rate is important but difficult, and it should be the goal of our dialysis unit and every dialysis unit across the world. Okay, time for your favorite part of the talk, the monthly quiz. Question number 1, what is ultrafiltration? Excellent. It's removal of fluid and some solute during dialysis using a semipermeable membrane and a driving pressure, again, that forces the fluid and the solute across the membrane. Question number 2. Ultrafiltration removes fluid from which compartment? That's right, so from the plasma volume, but when fluid is removed from the intravascular volume, we hope that fluid from the intracellular and interstitial compartments then moves in to replace the fluid that was removed from the plasma space. Question number 3, name 3 ways to reduce the ultrafiltration rate. Excellent. So you can decrease UF target, so just remove less fluid during a particular dialysis treatment. You can, of course, increase the dialysis treatment duration, or we can simply lower their interdialytic weight gain. So patients are encouraged to reduce the amount of salt and water that they consume. They'll gain less fluid and will take off less fluid during the treatment. Question number 4, named 2 ways a high ultrafiltration rate leads to adverse outcomes. That's right. Basically, if you remove too much fluid too quickly, you can cause intravascular volume depletion, which leads to low blood pressure during dialysis, so intradialytic hypotension. If you don't have enough fluid inside of your blood vessels and the pressure's too low, then you don't bring enough blood, you don't perfuse your organs appropriately, and this can stun your heart, your brain, your intestines, and other organs as well. Final question. What is the maximum UF rate recommended by CMS? Excellent. Uh, Thank you so much for your attention this month to the Halloween edition of the Northwest Kidney Center monthly in-service. I probably said some things that weren't quite right, but I hope you learned something anyway. This is Andy Brokenbrough signing off until next month. Hope you have a wonderful day.